So today we are going to talk about lipid disorders, and the common type of lipid disorders remember from your step 1 preparation are hypercholesterolemia and hypertriglyceridemia. The figure should be above 200 for total cholesterol, and for elevated triglycerides above 150 milligrams per deciliter. These diagnostic criteria and screening, generally in men, you start the screening earlier, about 35 years of age. In some countries, about 40, but if you see 40, 35 in the MBME exam, make sure you look out for that. In women, you can start a bit later at 40 or 45 years of age. If there is a risk factor like diabetes, obesity, and smoking, or family history of stroke or myocardial infarction, you can start as early as 20. And if there are genetic risk factor, you can then start at as early as 2 years old. So the treatment guideline is, first of all, we always want to make sure we do lifestyle modification. Non-pharmacological treatment comes first if the values are moderate or mild. So if the LDL is more than 190, this figure is what you need to remember for your exam. LDL value which is more than 190 milligram per deciliter, then you have to start with statins. If the patient is diabetic and is from the age of 40 to 75, you have to use statins, regardless of what the LDLs are. And it's prevention, in primary prevention, when you calculate the atherosclerotic cardiovascular risk, if it's more than 7.5, we no longer use 10%. Once it's more than 7.5, you start with statin prophylactically. So these three things, you need to remember them. They are very frequent points for exams. So when do you start statins? Remember that after 40 diabetic patient, if the LDL is high, if the triglyceride is high, or used for primary prevention, if you calculate the cardiovascular risk and it's more than 7.5%. For triglycerides, if it's more than 500, in some MBME questions, you probably see it for more than 1,000. But either ways, if it's more than 500 or 1,000, you want to use a fibrate. Fibrates are good, but because of their side effects, we are not generally used for mild to moderate hypertriglyceridemia. You always want to do lifestyle modifications in that, and also use fish oil, the omega-3 fats. Make sure you talk about diet, exercise. Niacin, we don't use it much because of a lot of side effects. And most of your practice, or most of your questions, the answer is always going to be statins. So you can use statins, and we should know that statins are first line. I always call them first line, second line, and third line. In some cases, when the statin is not enough, we are going to see some other medications like the PCSK, the evolizumab, which we are going to see very soon. So the common drugs and their side effects, we have statins, e.g. the HMG-CoA reductase inhibitors. Atorvastatin and rosuvastatin are the examples, Crestor, Lipitor. And the mechanism of action is by reducing the synthesis, by inhibiting the hepatic cholesterol synthesis. The side effects, because it's working at in the liver, it can be hepatotoxic. And also, commonly, you can have myositis, myalgias, and rarely you can have rhabdomyolysis. So the patient is using a statin, he started on statin, having pain and entering some acute kidney failure or acute kidney injury symptoms. Know that you have rhabdo and you have to stop the statin. This is in extreme cases. Most of the cases are able to tolerate it and it gets better. Niacin, we don't use that much, but you just have to know that it reduces the hepatic VLDL secretion, it increases the HDL, and the most common side effect is flushing, which usually when you take it with NSAIDs, you take it with ibuprofen, take it with Advil, and the symptoms is less. Or can also induce hyperglycemia, so be watchful when you're using a diabetic patient, and can also induce hyperuricemia, so be watchful in gout, patients with gout or tophi. Ezetimibe can be used for to support statins. It has mild side effects, and all it does is to inhibit intestinal cholesterol absorption. We have the fibrates, which we already talked about. What we do is they activate the PPAR alpha. You have to remember that in this case it's alpha, not gamma like the one for diabetes. So this is PPAR alpha, which increases the lipoprotein lipase activity and reduces the triglycerides. So the side effect of fibrates usually is gallstones, increases the cholesterol in the bile. You can have myopathy, especially when you use in combination with statins. Bile acid sequestrant, cholestyramine, is used a lot. Not usually for this purpose, but we use it a lot for other conditions, which we are going to talk about when the time reaches. But it's helpful to bind and reduce intestinal reabsorption of bile acids, and thus increasing the LDL clearance. Side effects: we have the GI upset and malabsorption of fat-soluble vitamins. Then the PCSK9 inhibitors, which is evolocumab or alirocumab. They are monoclonal antibodies that bind circulating PCSK, and these avoid the binding to the LDL receptors, thus lowering the cholesterol level. In severe hypercholesterolemia, we can use this in combination with the statins. They are more convenient to use. They are newer version of these groups, which you only have to inject twice a year. They are quite expensive, but it makes it effective and efficient because you don't have to take them every day. So what should you remember for your exams? For your exams, remember the risks of pancreatitis. You have pancreatitis caused by increased triglyceride is very high after 500, and usually very, very high after 1000. So you should start fibrates immediately the triglycerides above 500. And we talked about the statin-induced myopathy. So you should always check the CK levels if the muscle pain occurs. And for familial hypercholesterolemia, you should remember that they need high statins, because usually once there is a lot of deposit in the tissue, it's because there's a lot of deposits in the blood vessels wall. And to avoid stroke, MI, we need to make sure we treat this promptly. Always monitor the liver enzymes for when we start statins, and also remember to check. You don't usually stop it immediately except the values are extremely high. You expect some changes, so we don't stop it immediately except the values are extremely high or there are symptoms. If there are symptoms, you can switch to a less potent statin, or you can stop depending on what's going on. Then if you stop, you can restart again gently at a lower dose, or you can switch to a medication class. Drug interactions is the increased risk of rhabdomyolysis when we use gemfibrozil with statin. And adherence is very important, and we should always advocate for non-pharmacological treatment, even though we are giving meds. And that's all for hyperlipidemia. Remember, what we have to do is the diagnostic criteria, the figures which we spoke about, when to treat, and with what medications we treat with. Always calculate the cardiovascular risk factor, and if it's more than 7.5, even though there is no symptoms or any other risk, just make sure we start treatment with statins. as it has been proven to prolong, to improve